Let's get real. Let's get loud on America Out Loud Talk News. This is the McCullough Report and Focal Points Substack. I'm Dr. Peter McCullough, your host, and I want to welcome you to the program and provide a warm welcome to our guest who's coming all the way from the Great North, from the Toronto metro area, John Molinaro, who has a master's in behavioral sciences, and he's one of the top experts in North America on autism. John, welcome to the program.
Pleasure to be here with you, Dr. McCullough. Been a long-time fan, love the work that you're doing, and happy to be on the battlefield with you.
Man, I have to ask you the first question because, you look pretty tight. When was the last time you had a tie on?
Oh, I wish you didn't ask me that. It was a long time. It was a long time ago, but thankfully the knot stayed intact, so it's just a quick slip on.
Oh, there we go. I got to tell you, well, I'm a medical doctor, so I'm wearing a sweater today, but I always have a tie on underneath because I just finished with my last patient. But in the world of psychology, you guys have always led the way in terms of being comfortable and not being uptight and kind of having those soft and furry sweaters and things like that. So, but anyhow, when I go on TV, I always try to wear a shirt and tie and be respectful, and you're the same. Now, we have both talked in the past and, been out there in our observations about what we call an autism epidemic. And I certainly see autistic patients in my practice now, young people and older individuals, and in everyday life. When I do a public program, like I've done programs in the Toronto metro area, thousands of people show up, and I ask them, how many of you in the audience have been touched by autism? Meaning somebody or a family member or at work. The answer is about 25% of people raise their hand. That's not 25% with autism, but meaning it's they know about it. It's being influenced, and you've been working in this field for quite some time. So why don't you give us an update on what you see as this overall overarching problem of autism spectrum disorder?
Definitely, Dr. McCullough. So yeah, as we mentioned, I'm a board certified behavior analyst. And when it comes to autism and autism intervention, all intervention should be led by a behavior analyst, which is exactly who and what I am.
Mm-hmm.
And interestingly enough, Dr. McCullough, as prevalent as autism is today, I don't think a lot of people really understand what it is. So I'm excited to talk more about it, excited to let people know what it looks like and how many people it affects today. So,
well, why don't we start out just with the epidemiology statistics, and then we can get into the nuances of definitions and diagnosis, because I think that's where a lot of progress has been made. But what are the top line numbers in Canada and the U.S. in terms of autism, and is it going up or down?
Yep, great question, Dr. McCullough. So. And I really hope I don't scare anyone with these numbers. I think over the last couple of years, we've had more than enough fear. And the last thing I want to do is scare or discourage anyone. Right. But today, the number and the frequency and the prevalence of autism is around 1 in 30. I know it varies between the US and Canada, but today we're at 1 in 30, maybe 1 in 40 on average. Mm-hmm. And if we go back just 10 years, that ratio was 1 in 70. And then back in the year 2000, we're at around 1 in 150. And then prior to that, the numbers do get pretty drastic, and I don't know how accurate they are. But going back to the 80s, we were at 1 in 10,000. So even for error's sake, let's cut that in half and say in the 80s and the 90s, we were at 1 in 5,000.
Mm-hmm. Now, John, screening and detection. People have said, well, all of that is accounted for by screening and detection. What say you?
Yeah, so that's what the textbook will tell you, that the reason the prevalence has jumped so much, and we're talking several fold, is simply because we got better at identifying. Our tools got sharper. And I would definitely concede and say yes, that maybe that's a factor. But to go from, back in the year 2000, from 1 in 50 to 1 in 30, I don't think our tools got that much sharper. And again, that is just my opinion, my observation. But I think there might be more to kind of what's happening here.
Well, as you look around in general life, do you think organically there are more people with autism than there were 20 years ago?
I would say so. I would say yes,
Okay.
in my personal opinion, and even when I look back to my high school student body, I can't remember a whole lot of students that had this diagnosis. And when you look at it today, a few years later, it's much more prevalent. So I think organically, I'm seeing a natural increase.
I didn't tell you this before, but my wife is from Toronto, and she went to Parkdale Collegiate, if you remember Parkdale Collegiate in Toronto. And when she was going to school there, she can't remember anyone with autism at all.
Right.
She
Yeah.
can't even remember anybody with attention deficit hyperactivity disorder.
Yes.
None.
And again, I think there's a lot of people that might be watching this that are very science and evidence-based. So obviously this is observational, but I think nevertheless, it still holds a lot of weight.
Sure does. Now, explain to us this Diagnostic Statistical Manual, DSM, and just the working definitions of autism spectrum disorder. Help us out there.
For sure. So what I'll do, Dr. McCullough, is I'll give you the DSM definition, and then I'll give you the layman's John definition. Okay. So in the DSM, autism spectrum disorder is characterized by persistent deficits in social communication and social interaction across multiple contexts, along with restricted repetitive patterns of behavior, interests, or activities. Okay, so that's the very clinical term. And now in my term, I would qualify it as a neurodevelopmental condition that impacts how someone communicates, how they interact, and how they experience the world around them today. And if I can even go a step further, it's a difference in how someone inputs and outputs information.
Okay, that's very good. So, I've heard that, well, there has to be 4 criteria or 2 out of 4. In your view, I mean, is it a matter of like checking the box, or is it, if you take an expert like you, is it your clinical impression that you make the call?
Great question, Dr. McCullough. And I do want to preface that as a behavior analyst, we are not able to diagnose. So I am not the one delivering diagnoses by any means.
Okay.
But I have worked with professionals in the past, and I have sat in and observed some of these more gold standard assessment tools. And so it's a matter of looking at a whole at these different developmental milestones. And it's not just like, okay, well, this individual is impacted socially, so they're labeled autistic. No, the gold standard in ADOS assessment, which is the gold standard tool, it's a very in-depth, very sterile assessment where it looks at all sorts of different developmental milestones. And as a whole, it determines whether or not you meet criteria. And if you do, what level of severity do you meet that criteria?
So what does that stand for?
ADOS, Autism Diagnostic Observation Schedule, I believe.
Schedule. Okay. And then how is it graded in terms of severity?
So there's 3 levels that often follow a diagnosis: level 1, level 2, level 3. And essentially what those levels mean, Dr. McCullough, is it's the level of support that a learner or an individual might need throughout development or throughout their life.
Okay.
So
So higher means more support, or?
Correct. So a level 1 would mean some support might be required. Level 2 would be more substantial support, and level 3, very substantial support. Again, I don't create the naming conventions, so.
Right, but is level 3 the max?
Yes.
Okay, so why don't you describe to us the characteristics of a level 1, 2, and 3?
Absolutely. So a level 1 learner, which, and I qualify them as learners because in my clinic, we work with young kiddos between the ages of 1.5 up until 6. And I do have experience with adults as well and teens, but for the majority of it, we work with young kiddos. And so a level 1 learner might have developed some communication where they have words, they're able to engage back and forth with language. They might be very fluid with language, but where they might require some support is that social piece, where more deeper, meaningful, reciprocal social experiences, they might require some support. or also with transitions. So they might have some rigidity when it comes to daily routines. And again, it's just an indicator that a level 1 learner is going to require some support. And I also just want to be careful that I'm not trying to overgeneralize. The phrase goes, if you know one individual with autism, you know one individual with autism. So again, this is a general overview. So that would be a level 1 learner that would require some support. But if we go to the level 3, which is on the other end of the spectrum.
Well, actually, do level 2 if you don't mind. Do level 2 for next. So.
Okay, so level 2, it kind of just blends level 1 and level 3. So if I can go to level 3, it'll just help the conversation. So a level 3 learner, oftentimes there's no communication that's developed, no language, no words.
None. People say nonverbal.
Correct.
Okay.
And also what often follows that is a high level of sensory behavior. So these particular individuals might engage in self-stimulatory or stereotypy a very significant amount of their day. Okay. And often what follows a level 3 learner is aggressive behaviors, inability to regulate when they are, emotionally triggered. And lastly, self-injurious behaviors. And again, this is not all level 3 learners. This could, some of these might apply to you. That's why it's indicated of a spectrum disorder, right? So, and then a level 2, Dr. McCullough, will be somewhere in the middle, right?
Okay. So level 3, sometimes in the airport, I'll see kids, I presume they're autistic, but they're wearing noise canceling headphones. But why is that?
Yep. So again, that often could indicate a level 3 learner, but that might also apply to a level 1 learner. And it could just mean that in terms of their sensory regulation, or again, how they input information, might be on such a high sensitivity level that a lot of sounds or too many sounds at once is just overwhelming. And to be honest, you don't have to have an autism diagnosis for that to apply to you. I know when I go into a mall, I can't wait to get the heck out of there. So.
Okay. Now, so this autism spectrum disorder. So on this autism side, this what Leo Kanner described, this level 1, 2, and 3, isn't there another axis of intellect, so intellectual function?
So that's a great question, Dr. McCullough, and it's funny. I'm glad we're talking about autism and we're educating a lot of people, because again, I don't think a lot of people know what autism is, and I don't think it's ever described as an intellectual disability. Okay, so you can have, again, a very severe level 3 individual with autism whose IQ is at par, right? Or if not higher. But again, I don't know, and I don't want to be quoted for this, but I don't think there's research out there that an autistic individual naturally has higher levels of IQ or lower levels of IQ.
But didn't Asperger originally describe, I thought, was actually higher IQ or very high functioning? Some people consider children with Asperger's as part of this syndrome of having kind of super functions. Is that not right? Or
yeah. So again, like today, Asperger's obviously no longer a term that we use. But yeah, that would be defined, like that would define more of like the level 1 learners who are able to function. And again, they'll be called high functioning autism. But again, we no longer use those terms. But in my research, Dr. McCullough, I haven't come across like articles that say if you have Asperger's, you're much higher intellectually.
Okay, maybe that's just something that just got into the popular.
And I could be wrong. Happy to be wrong if I am.
No, but linguistics. But this is good to correct this. Now, another feature that I notice with autism, particularly in like younger adults, is the inability to hold a gaze. That is, to look somebody in the eye and communicate. Is there anything to that?
Again, another great question, Dr. McCullough. So there's some individuals on the spectrum who very much have issues with eye contact. Why that is, I'm not entirely sure. I like to venture a guess and say it's more of a sensory challenge. So, for a lot of people, again, diagnosis or not, gazing into someone's eyes can be very intimidating, right? So I think it's more a matter of It's uncomfortable. It's too much for me.
Mm-hmm.
And I know people who are not on the spectrum who also have that challenge. And furthermore, Dr. McCullough, like I mentioned, you could have an autism diagnosis and have absolutely no problem with eye contact.
Okay. Now, let me ask you another question. Are children with autism, are they born normal and then they develop it during early childhood, or how does this onset happen?
Another very powerful question, Dr. McCullough, and I feel like this might be getting out of my expertise as a behavior
Mm-hmm.
analyst. I'm not entirely sure. So all I know is when children come seeking support, sorry, there's a car alarm going off.
Mm-hmm.
But when children come to me to receive services, again, they're around 2 years old, maybe they have a diagnosis and they've been exhibiting some symptoms for a little while. So it's a great question. I'd be very curious to see between the ages of 0 to 8 months, 0 to 9 months, what does
Right.
that look like?
But John, do the parents tell you that their perceptions were that the child was normal, and now at age 2, they're clearly not normal? Is that what they tell you?
There have been times where I've had that conversation. And, generally speaking, when I do an initial consultation, I will try to get some medical background, right? Do they have any
Mm-hmm.
other comorbidities, any other diagnoses? Are they generally healthy? What does that look like? Family history of mental health, things like this. And there have been times where parents kind of willingly let me know, hey, listen, I actually noticed a decrease or a regression after 1 year, the 1 year
Mm-hmm.
shots or something like
Mm-hmm.
that. So
Right. Now, do some of these children with autism, do they also have ADHD? When we get old enough, you can figure that out. Do they overlap?
yeah, so again, that's a great question. So because the kiddos that we support are, between the ages of 2 and 5, and because I'm very familiar with hyperactivity and what that looks like, I'm able to see some of those symptoms. Now,
Oh,
do they
really?
have a formal diagnosis? More often than not, they don't. And it's because a lot of family doctors don't want to be giving out that diagnosis at such a young age, and rightfully so. But I have had at least 3 or 4 formally diagnosed children that also did have ADHD, and a whole bunch of them that weren't yet diagnosed, but again, difficulty regulating their body, keeping still, focusing on tasks, even if the tasks were motivating. So I would definitely say that I do see a connection between both of these diagnoses, as well as anxiety as well.
And at what age do you think legitimately a child could be diagnosed with ADHD?
That's a great question, Dr. McCullough, and I think maybe I'll return that question back to you.
Mm-hmm.
Um,
Well, I
so
think clearly by the time they get in organized school, maybe K through 12, I would say.
yeah,
But
so I think that's fair. And then I want to throw it back to you in a sense of like, why do we want to diagnose a child with ADHD? And for me, the only reason, it's not to medicate, it's not to start exploring pharmacological interventions.
Mhm.
It's more so, let's identify this child as learning differently than other people and is
Mhm.
going to need support,
Yeah,
right?
no, that's very fair, and it's important. It's important to have the understanding. I had an adult with autism in my office about 2 weeks ago, and he sat down, and his mother needed some attention, and he literally sat in the chair for like 30 seconds. Then he was up. He just walked into every room of the office. He just couldn't. He just, back in the olden days, we say it's somebody who couldn't sit still, or
Right.
someone who had ants in his pants, and he just couldn't sit still. And I was like, oh my Lord, I got so uncomfortable. I said, he's gonna get into something. I was hoping maybe somebody's computer is gonna get erased or something. But it was just a feature of it. And well, what I know from the published data, for whatever it's worth, it's about, of those with autism, it's roughly about a third also would meet some criteria of ADHD as they get older. Now, of those with ADHD, we're talking about attention deficit hyperactivity disorder. About 8% would meet a diagnosis of autism. So it's not an equal kind of part of the Venn diagram. And that I imagine another comorbidity must be epilepsy or seizures. So do some of your clients have seizures?
So again, Dr. McCullough, my practice is fairly small, but in the years I've been doing this, I haven't seen a vast majority of my autistic individuals having epilepsy. I have heard from other colleagues that some of their students might have absent seizures, so a form of a seizure disorder. But in my personal experience, I haven't seen that all that much.
Okay, good. Again, the published literature says that's about a 10%. And then the last one to ask about is on the neurologic side about tics, that involuntary facial or motions or gutterances, kind of half the side clicking like this, or sometimes a guttural tic would be like
Right.
like this.
Yep.
Have you seen that?
So I have actually in again my 5 years of being a behavior analyst, I've run into two kiddos that did have some tics.
Okay.
But more, I would say, Dr. McCullough, more prevalently, the ADHD is a big factor, anxiety for sure, and also GI issues, right?
Well, yeah, that's what I was going to ask is
Yeah.
GI. Now, one of my observations about autistic people, maybe I'm wrong on this, but I think if anything, they tend to be on the leaner side of body mass index. I mean, I know obesity is possible, but it almost seems like the kids seem skinny, some of them, and GI disturbance, so abdominal cramping, diarrhea, constipation, being pale. Sometimes they can become anemic. Does that fit your observations?
It does. And I want to stay in the practice, the scope of my practice. I'm not a nutritionist. I can't speak to it. But I'm very much of the idea that diagnosis or not, a healthy gut, exercise, getting sunlight on your body, like these are all indicators of behavior, right? Whether you have a diagnosis or not, if your gut is all disturbed and your biome is unhappy, your behavior is going to reflect that.
Right. Right, Jonathan, we're going to get to therapy in a minute, because I know people always want to get to, like, what do I do about this? But I'm just trying to paint the picture so we can understand the illness without yet getting to therapy. So help us understand this diagnostic journey that, let's say, a child born normal, the parents start to notice something that's not right around, 18 months or 2 years, or I mean, isn't it true most if they're going to develop autism, it'll happen before age 4? Isn't that true?
Yes, that's from my understanding that's very true. And so I'll speak on behalf of Ontario because that's obviously where I'm from. But yeah, the typical journey for a family who undergoes a diagnosis is, like you mentioned, it kind of starts with identifying those red flags. And that could come from parents or loved ones. I also see a lot of times it actually comes from daycare staff or early education staff that start to notice, hey, listen, the milestones are not quite there, or we're noticing these atypical behaviors that most of our other students are not doing. So then from there, these red flags are noted, and the parents will take these concerns to their GP, to their family doctor, where often the first level of screening is done. And then from there, if the GP indicates that, yep, you know what, there is some cause for concern, I'm going to go ahead and send you over for a more in-depth assessment at a specialist. And then right then and there, that specialist has the ability to give you a diagnosis, or there's also a level further, which is that ADOS assessment we spoke about. So that's kind of the gold standard indicating, do you meet criteria, what level you are, what areas of need are there. But the specialist is also able to do that as well.
Now, is the specialist like a PhD in psychology or an MD?
Yeah, that's correct. Yes.
Is it mainly PhD in psychology?
I think there is a variety, but like definitely a speciality in like child development.
Okay. Well, can somebody at the master's level, let's say somebody who has a master's? No.
No, definitely PhD required.
So it's a PhD, like a child psychologist in general. So,
But
so
I
I
just don't
imagine
think
the
it's
child psychologists are pretty busy, right? They probably, I mean, is there in Ontario, is there a waiting list to see one or?
absolutely. So again, I don't think it's exclusively psychologists that can offer diagnoses. I think other PhDs have that specialization.
Mm-hmm.
But yeah, wait lists is a monster that I'm excited to get into with you and let you know what that looks like.
Yeah. Wow. Well, listen, we're nearly at the midpoint. Let's take a break for our commercial sponsors. You're listening to Focal Points and America Out Loud Talk News, McCullough Report. We are talking to John Molinaro. He's a behavior expert, someone who every day is working with autism. And autism is something that's really come up on our radar screen as the childhood epidemic, essentially, of our generation and generations that we're observing. So we're going to take a break here, and we'll be right back. Let's get real. Let's get loud on America Out Loud Talk News. This is McCullough Report and Focal Point Substack. You're listening to Dr. Peter McCullough, your host, and John Molinaro from Toronto metro area. Listen, I was pulling for the Blue Jays hard. And, it was extra innings and a broken bat and a lot of sorrow as, the Dodgers were the heavy favorites. But I'm sure in the crowd were some young people with autism, maybe wearing noise-canceling headphones and try to enjoy what's going on. But we're talking about this diagnostic journey that they go on, the waiting list. So why don't you pick up with, what is the family going through as they're trying to figure out what's going on?
Absolutely, Dr. McCullough. Great to be back. So wait lists are a term that a lot of families recently diagnosed are very, very familiar with. Mm. And the first wait list that a family is kind of posed with, unfortunately, is that gold standard assessment. So as I mentioned, there's kind of two avenues a family can receive a diagnosis. One is just from a specialist that's able to do their assessment and let you know, yes, they meet criteria or not. And then there's that gold standard assessment, which is much more detailed, longer, more clinical. And there is a wait list for families to get to that gold standard assessment. And that could look upwards of a year since the last I've checked.
So in many ways, maybe they're a year behind in therapeutically, right? Because
unfortunately.
Well, let me ask you this. Like with any illness, is it better to start interventions early for this problem or does it matter?
Absolutely. I can't think of a single diagnosis where it's not better to start early, right?
Okay.
Yeah.
Okay, that's a strong answer. Good.
Yeah, so absolutely. So that year of a wait for families is a lot of lost time. Or again, they can go the private route and pay for it themselves. And I think that looks at a cost of north of $3,000. And again, don't quote me on that. It could be.
But is there, in the Canadian system, if you go private, is it a little shorter wait, or is there still a wait to see a private?
Great question. I imagine there might be still some wait, but definitely not a year.
Okay, so the clinical psychologist in Canada, that would be kind of on OHIP, the provincial health plan. Is that right, or?
That's another great question, Dr. McCullough. I'm not entirely sure. So to go the private route, I don't think, or I'm not sure if OHIP does cover that.
Yeah, but I'm sure the other ones, the public ones.
Oh, yes, my apologies.
Yeah.
And that's why there's such a wait list, right? Is because it is funded. Families don't have to pay for it. And so that's why there's such a lengthy wait list just to get that assessment.
But is the wait partly due to the fact that it's literally just a supply and demand situation? So if there were more child psychologists in Ontario who accepted OHIP, what have you, then the kids would be they'd move through more quickly.
Definitely.
Right? So a good point for all of you young people out there looking for careers in healthcare, child psychologist and having some expertise in autism looks like a pretty good career. Looks like you'd have a lot of job security right now.
You said it.
Yeah.
It comes with a lot of burnout. I'll tell you that.
It has to. Oh, it has to. It has to. And it's not, I'm not saying it's an easy pathway.
Of course.
People at the PhD psychology level, that's a really long haul to get there, but it sounds like it's a serious diagnosis. People take it seriously. So they get a diagnosis and start to explain to us what this therapeutic journey is that the parents and the child can expect.
Yeah, definitely. So once a diagnosis is received, the next is they'll be directed towards the only real evidence-based therapy that there is, which is ABA, Applied Behavior Analysis, or otherwise known as behavior therapy. So that's kind of where the journey of treatment really begins. And so if you want, Dr. McCullough, we can talk before I kind of describe what it is, or maybe I describe it first, and then we could talk about like the costs associated with it, the time.
Yeah, let's talk about what it is.
Sure.
So people can, and you said it's the gold standard and it's evidence-based. Now, when I talk to a lot of parents with autistic children, they want to talk about lots of wild things, but they rarely bring this up, to be honest. Now, maybe it's always there and it's in the background, but why don't you tell us, what are the gold standards here for this behavioral therapy?
Yep, absolutely, Dr. McCullough. So as I mentioned, ABA therapy is pretty well the only evidence-based therapy for autism intervention that's withstood the test of time. And so founded back in the 60s by 3 different psychologists, but I want to make note of one particular psychologist that's called the father of ABA, if you will, Ivar Lovaas. And so it'll come up later on why I want us to make note of his name. But essentially what ABA is, Dr. McCullough, it's the science of learning and behavior. So clinicians like myself, we use behavioral principles to assess behavior, measure behavior, and then collect data on triggers and consequences and functions of behaviors. And then we use that information, we use reinforcement and motivation to either increase desired behaviors or decrease not so desired behaviors. So that's kind of a nutshell of what behavior therapy is.
So it sounds like it's very structured and organized. So keep going.
Yep, that's correct. And it is. And it nowadays, it's very heavily dependent, again, on reinforcement and motivation. And with ABA, there are different avenues, which I think are wonderful. The discipline, the practice itself continues to get better and grows year after year. And there's different avenues where the more traditional ABA is more intensive. It's designed to be more intensive, more tabletop, clinician-led. But there are different avenues of ABA where they're much more naturalistic, much more play-based and child-led. So the discipline keeps growing, keeps learning. And the whole intention of it, Dr. McCullough, is we want to target socially meaningful behaviors for each learner. We want to give them independence to be who they are and function in their everyday life without the need of any support. That's the ultimate goal of ABA.
Wow. Well, sounds terrific. So give us an example of a behavior that in your experience is pretty modifiable, that it's responsive to what you do.
Great question. So it's interesting. Behavior really applies to anything, right? And it's funny, ABA and behavior analysts are also working in the field of animals because animals also have behavior, right? So the overall science is not just exclusive to autism intervention, right? And it was actually Ivar Lovaas that brought it to autism intervention years and years ago.
And how do you spell his last name?
Lovass.
Lovaas. Okay. Yes. So he's kind of the father of this. Okay. Yeah. So give us an idea. Just pick one common behavior that you would consider to be aberrant that you get on track with your approach.
Sure. I think the first thing that comes to mind is language. So again, a lot of the learners that come to us for support, they either have very early language or they have no language whatsoever yet. But they do have the telling signs that language might be on the horizon for them.
And so what would be the typical age that you'd kind of get involved here? How old would the child be?
Like how early can we do ABA?
No, just a child where language you think is going to be modifiable. Just give us an idea of an age, like 4-year-old or 3-year-old, or?
I would say earlier than that. Like we've worked with families where even around 2 or 3, we were able to start getting some language from them.
Really?
Yeah,
Wow.
absolutely. And again, it's not really indicative of the ABA or of the learner itself. I think it does depend on the severity of your diagnosis. Like I
For sure.
mentioned,
Yeah,
yeah.
for sure.
But going back to your question, Dr. McCullough, a lot of the behaviors that we kind of start with ABA is language, is requesting. So that's one of the first things that we will use ABA for to increase that behavior.
Okay. But you think it's responsive that you can, you know, in medicine, I'm always looking for things that are, quote, fixable or responsive. So you think language is something that you can clearly modify. You can actually start to bring it out in a child who's nonverbal. Is that right?
So I think I'll phrase this very, very particularly. So I think ABA gives you that platform that if language can and will develop, ABA will help bring that out. But there's
Okay.
also, on the flip side of that, Dr. McCullough, there's unfortunately a lot of like level 3 children, level 3 learners that even after years of ABA, after years of parental involvement, everyone's on board and we're all trying really hard, that language doesn't develop.
Really? You mean so they could be 10 years old and not say anything?
Unfortunately, yes. And I don't think
Oh
that's
my word.
indicative of successful ABA or unsuccessful ABA. I think there's a lot of factors there. And to be honest, it's maybe out of my understanding, but that's just something I've experienced in my professional journey.
Mm-hmm. Mm-hmm. And so, so the types of give us an idea of something you could do as an exercise where you start to bring out language in a nonverbal autistic child.
Absolutely.
How is it done?
Great question. So if you recall earlier, Dr. McCullough, I mentioned there's different avenues of ABA, some more intensive, some more clinician-led, and others more naturalistic, more child-led. And one of those avenues is actually called PRT, which was developed by Lynn Cagle, and it's so rough. I'm blanking on the name. Anyways, lovely people, excellent people, but they've established a form of ABA that's called PRT, pivotal response training, that's much more naturalistic, much more, again, child-led and motivational. So for example, if I'm trying to teach a kiddo how to request for, let's say the term is car, I'm going to use, and hopefully they're motivated by cars. Hopefully it's a young little guy who loves wheels and cars. So what I would do is I would play with the car. I would engage with the car and very just gently and easily label car. And just exposing them to the label and making sure I'm not over labeling things or over communicating, just making it very clear that this item that you like a lot is called car.
Okay.
And then perhaps once I build trust and build a great connection with them, I might put that car out of reach, or I might put that car somewhere else and see what they give me. Let's see if they reach for it or what their initial reactions are to requesting. Because it's very unlikely that the first thing, if they're nonverbal or if they haven't developed language yet, that they're going to be like car. But the first level of intent might be grabbing, or it might be joint attention where they look at me and they look at the item. And that's where we would start. We would start reinforcing the intent and slowly shaping it to see, hey, will you eventually give me a sound instead of a look? So does that?
So if they let's say you do that, and they kind of going for it, do you tell them this is a car or a car? Do you keep working on that until once you've identified the intent they want to go for it?
Yep, exactly. So that's when we have to be very clinical with the reward and the reinforcement. And in this circumstance, the reinforcement would be the actual car, right?
Okay.
So it's all about applying reinforcement and clearly specifying what behavior do I want to reward at this point in time. And shaping is a big behavioral principle that all BCBAs practice. And sometimes it's required. And first, we need to walk and reinforce walking before we can reinforce running.
Wow. And so are the parents kind of involved in this training the whole time too?
Great question. So I think different agencies have different levels of involvement for parents, but I know that with pivotal response training, and I think just globally, ABA as a field is definitely involving parents a heck of a lot more, and rightfully so. The whole idea is we want to generalize these skills, right? We don't want the child to only perform in the clinical setting or in the school setting. We want to generalize these skills, not to mention that the parents often spend a lot of time, more time with the students than we do, right? So parental involvement is something we very much strive for.
And did you say it's called pillow response testing?
Pivotal response training.
Pivotal. Yeah, pivotal response testing. Okay. So, I mean, what you're describing to me, John, is very effort dependent. It's very structured, and you're working through these principles. And it sounds like an average parent wouldn't necessarily intuitively know these steps, right? I mean, they have an autistic child. They're waiting to try to see, trying to get a diagnosis, trying to see an expert like you. It may be more expedient for just general life if the child is plumped in front of a TV or given a video game or a cell phone. Do you see that in your day-to-day life where the kids, the autistic kids, maybe just because of the parents are busy and other things, they literally just have some electronic source of stimulation?
Absolutely, Dr. McCullough. And that actually, in my observation, that goes for both autistic children and non-autistic children.
Mm-hmm.
And the only difference is oftentimes the autistic child, of course, much more high demands. They have much more high sensory needs, or again, unable to communicate. So they demand a lot more attention and effort from parents. And I mean, parenting is already hard enough. So I definitely see a lot of parents kind of resorting to these quick fixes. And it's not to place blame. It's not judgment at all. I think life is hard, and I get it. But this is very much something that I am seeing, especially with children who are on the spectrum.
Yeah, for sure. I remember I kind of grew up in a lower middle income household, and 3 boys. We were close in age, and back in the olden days, we would literally just create a lot of frustrations for my mom. She would say, "Go outside, go in the backyard and play. Just kind of get out of my hair." For expediency. And I think parents throughout, the millennia have done that. But it sounds like with an autistic child, to just kind of get the child out of their hair, whether it be sit in front of a TV, play a video game, what have you, or it sounds like it's not helping them overcome these essentially disabilities.
I couldn't agree more, Dr. McCullough, and nor do I think families are intending to do that.
No,
right?
they're not. It's just part of a busy life, right?
You said it. And again, my compassion and my heart goes out to all the families. I've had the blessing and the pleasure of working with 60 to 80 different families in my time, and each and every single one of them are doing their absolute best. And again, my heart goes out to you guys. I understand the frustrations and difficulties. I get it. And oftentimes when I'm more than burnt out as a parent and I have a child that I know has very high demands, who's very rigid, who I know can enter into a tantrum at any given moment, yes, the iPad is my savior. And and a lot of these parents are aware that, hey, I don't want to be doing it, but it's how she goes.
Yeah, it's clearly this kind of reality we have to confront. Yeah, I wanted to comment and see what your reaction was. Leo Kanner in the 1940s, who was credited for describing autism initially, he made an observation in his initial monograph, which I read, that he thought the parents of autistic children were exceptional. That they're just exceptional people. And, I've had a chance to I spoke at a big autism event last year, and I've interacted with people, not maybe those who are just coming out to various seminars, what have you. But it's my conclusion as well that parents of autistic children, they seem to be exceptional people, meaning successful and perceptive. And have you generally garnered that type of conclusion as well?
Absolutely, Dr. McCullough. All the parents I've had the pleasure of working with, in each in their own individual way, are remarkable. And I think life and having a child with special needs, it demands that of them.
Yes. Okay. So that's what I wanted to get to. So having a child with autism, in a sense, makes that parent become more exceptional, or do you think there's really something to it? Cantor thought that there was some type of unique segregation, that the autistic kids just naturally have more exceptional. I mean more intelligent, more assiduous, more diligent than the average. That it's not just born out of necessity thing. What do you think?
It could very well be. I know genetics obviously play a huge role in life. Mm-hmm. So, incredible parents, it doesn't strike me as odd that they breed incredible children, right?
Mm-hmm. Well, there's also too a statistical, and this is in a McCullough Foundation report on autism spectrum disorder. There's also statistically older parents have a higher risk of autistic children. So, older parents, you can be a lot more exceptional as a man when you're 40 than when you were 20, right? So, I mean, are the parents of your clients, are they on the older side as parents?
I would say the vast majority are in the average age group. I haven't seen any outliers where, either the mother or the father are, older in age, not in my small practice.
Okay, but how about young? Do you have any parents who are, not, younger than 25 with autistic kids?
I think maybe in the few years I've been doing this, I came across one family with a pretty young mother in the early 20s. Again, my sample size.
But John, how about any teenage parents? Have you had any teenage parents with autistic kids?
I have not.
Yeah, it's just interesting. Mm-hmm. I mean, people have said, for instance, the Amish or the Mennonites or certain groups have lower rates of autism. But, of interest, they also have children at a very young age. So, I had a patient today, and she's already a grandmother. And, it's not related to autism at all, but she's 48, and she's a grandmother. I mean, I'm 63, and I'm not a grandfather. I mean, that goes to show you. I mean, that's the difference. So those are very interesting. In this last part we have, I want you to kind of lay out this therapeutic journey and what do you see on the horizon? That's one of the reasons why you reached out to me, is your kind of vision for the horizon here as there's more and more children with autism spectrum disorder. It sounds like the autism behavioral therapy approach has grown and matured over time. It sounds like it's a bedrock. It's had substantial improvements. But what do you see, on the horizon?
Absolutely, Dr. McCullough. Thank you for paving the way for me there. And so I think my overall thesis, Dr. McCullough, and why I reached out is, I've been in the field of ABA now for almost around 10 years. And I've worked with a lot of children who are those level 3 learners, who I can see that they're going to require support. I'm not even sure how long or what that end goal looks like, but they are going to require support indefinitely. Mm-hmm. Not everyone, and ABA is wonderful, and ABA definitely, even those children will help. It's got a very high success rate in progression. And there's a reason why that is. Essentially, ABA, Dr. McCullough, is a highly trained professional doing almost one-on-one teaching at a very individualized level. Mm-hmm. So there's not many learners in the world who are not going to benefit from that. But again, I wanted to focus on those learners that are level 3 that are going to be, in the system getting ABA therapy for many years, not to mention the cost that's associated with it.
Oh, yeah. Yeah, tell us about that. I don't even want to know. It sounds
Sure.
very expensive.
Yes. So, so just real quick, Dr. McCullough. So ABA therapy can be, I guess, prescribed to a patient or to a kiddo anywhere between 15 to 30 hours a week of ABA
Oh, my
therapy.
Lord. Oh, my
Right.
Lord. That's
Yeah.
a ton of time. That's
Exactly.
is that like almost every day?
Yeah, it has to be. Yeah. So it's a full-time program. And again, rightfully so, because these particular individuals in a mainstream classroom are not going to get the same benefit. They're not going to get individualized teaching, right? And like one-to-one learning. So rightfully so, but it often takes place of school. And again, the cost, it can range a family anywhere between $40,000 to $80,000 annually. And here in Ontario, Dr. McCullough, the wait list to get funding is at least 5 years. So
Oh my gosh, that's from the OHIP, the government funding?
the Ontario Autism Program, yes, there's
wow.
like families have to apply after they get a diagnosis, and 5 years is kind of a
A
minimum.
5-year wait. So they actually have a government program. So autism is that common in Ontario.
Correct.
You have a whole government funding program. And this is in addition to school. So the parents get their kids from school and then they go to their specialist.
Yep. And so again, it would
After
definitely
that, oh my Lord.
Yeah, so it would rely heavily on, again, the functionality of the child, right? Some
Sure.
children are able to go to school and do great and only require a few hours a week of ABA therapy. But I would say on average, 15 to 20 hours for a lot of autistic
So
learners.
it's most days of the week.
I would say so, yes. And that's why it often replaces school. Like school becomes the adjunct, the secondary.
Oh my Lord. But what about a child who's in, let's say, second grade? How do they, so they must go to elementary school and the parents pick them up and then they take them to you.
Yep. And so again, Dr. McCullough, it would recommend on the needs of the child, right? So some children being in school, being in a school program is actually more beneficial, and ABA can be secondary. And it's because the child is thriving well in school, again, might not need that much support, and ABA can be the supplementary intervention. But I think more often than not, it's the reversal. And so, yeah. And so it was after realizing this, Dr. McCullough, that I started to think, okay, what other forms of intervention can support ABA? How else, is there any compounds or anything we can do to maybe help stimulate the brain in a different way? And ABA is wonderful. And it definitely also impacts neurology, and it does change the brain, but not the same as like a pharmaceutical stimulant would, right? Not to mention, Dr. McCullough, that a lot of these level 3 learners who, let's say, are very aggressive, who do have self-interest behaviors, when they turn 15 years old, options for them become more and more limited. And if you're, 6'2", 15-year-old child with or young adult with autism, and you're very aggressive, more often than not, you're put on pharmaceuticals. You're put on antipsychotics to mellow you up. Sorry?
Oh my Lord. So you mean somebody would just bang their head again? They'd be some big, large person. They bang their head on the wall or start punching somebody or.
Yeah. And again, I don't want to say that all autistic people are like this, but those are definitely some instances. Those are definitely some cases. Or even outside of the aggression, Dr. McCullough, the self-stimulatory behavior. A lot of these level 3 learners, or, it also applies to level 2, level 1, they might have a very intense self-stimulatory inclination where most of their day, they just want to stim. They want to either verbally stim or visually stim. And for an ABA specialist like myself, it's very hard to compete because no matter what.
Does that mean like a video game or?
Not necessarily. It's more like the more traditional, like hand flapping or rocking that we see. So that's more the self-stimulatory behavior I'm kind of referring to.
Oh, I see. So it's a physical thing. Now, did you mention that the level 3, which is the more severe level of autism, did you mention, I don't know if I heard you this right, but did you say that they ultimately, when they grow up, they become gay or LGBT? Is that true?
No,
You didn't say that. Okay.
no, not
Okay.
me.
All right. Um, okay. Well, listen, we're nearly at time. So it sounds like in the future, do you anticipate that there will be drugs that are specifically approved for autism? I know you're not a
Yes.
drug expert, but do you see that clinical need?
So I do believe so, and I'll try to compile this very
Yeah,
wild
quickly.
thought.
We only have about a
Yes.
minute, so.
So long story short, Dr. McCullough, it's these level 3 learners, these high STEM, persistent
Mhm.
STEM and aggressive students that I started thinking of. And then being somewhat of a hippie myself, I started thinking, is there a natural compound? Is there something or organically
Mhm.
more homegrown that could help stimulate the brain? And I started doing research into psychedelics. And the research
Wow.
is absolutely incredible. And it continues to get incredible. And one thing I made mention to Dr. Ivar Lovaas, who's the founder of
Mhm.
ABA, in my studies of psilocybin and autism, psilocybin and children with autism, Ivar Lovaas's name came up, and he actually participated in a clinical study where they took 2 children with autism, as it was around 4 years old or 5 years old, double-blind placebo, and administered LSD. And
Mm.
this was not uncommon in the 60s and the 70s. There's a few
Mhm.
studies like this, Dr. McCullough. But the main intent of it was, do we see a decrease in self-stimming behaviors? Do we see an increase in eye contact and social behavior?
Mhm.
And surely enough, the results were very positive. So much so that he encouraged the continuation of this study. And
Hmm.
there's 6 or 7 different studies like this, Dr. McCullough, where people were administering psilocybin, LSD, to children with autism in larger quantities, where there was a study of 15 kiddos, there was a study of 50
Mhm.
kiddos, all of which showed promise. And again, these are done in the 60s. So there's a lot of work that needs to be done. And I'm not encouraging anyone to go ahead and start dosing your children.
Right. Don't
Um,
go out and do this, but I think we do need to. Yeah, I'm a drug prescribing doctor, and I do think that behavioral therapy has gone a long way, diets and other things that parents have done. But I think there's probably got to be a role for drug therapy for these level 3, profound autism cases. So we're going to have to leave it here, John. Thank you so much for joining us. It's been a great interview.
it's been a pleasure, Dr. McCullough. God bless everyone. Thank you, guys.
Wow, great interview. Let's get real. Let's get loud. On America Out Loud Talk Radio, this is the McCullough Report and Focal Point Substack. I'm Dr. Peter McCullough, your host. Thanks for watching and listening.